The next session will be about the meniscal extrusion, a pathway to early OA by Prof.Bancha Chernchujit. Please, Prof.
Okay, good afternoon. I'm talking about the meniscus extrusion, a pathway to early osteoarthritis. So the degree of meniscus extrusion or meniscus extrusion index can divide into mild, moderate, and severe, okay? 20%, 20 to 40, and more than 40%. So the meniscus extrusion that may affect the mechanics of the knee joint. And as I said, the cardiac loss is about 1.4% per year. And there's a high rate of subchondral pathology like osteonecrosis, right? When you see osteonecrosis, thinking about root tear or meniscus extrusion. So the medial lateral meniscus area different. The lateral side always have less extrusion because that's a ribber ligament that attach. The cause of lateral meniscus extrusion can be from radial tear in ACL or discoid meniscus. But on the medial side, it's mostly from the root, radial tear or degenerative meniscus. Look at the classification. You can have the normal, or we call paraphysiologic meniscus extrusion, can be from pathologic, like you have root or the radial tear. You can have pathologic meniscus extrusion and degenerative. So many times you see early OA and extrusion without meniscus loose tear. That's because the osteophyte of the medial side attenuate the medial tibial ligament. So that can cause extrusion without the meniscus tear, okay? So this is a conclusion of the three causes. So look at the paraphysiologic meniscus extrusion. Mostly it's less than 20%. The paraphysiologic extrusion is functional meniscus without meniscus tear. 65% caused by meniscal tibial ligament abnormalities. The extrusion less than 3 millimeters away have no symptoms, but the patient start to have pain when there's extrusion more than 3 millimeter. So the pathologic meniscus extrusion is this controversy that extrusion first or root tear first. It's like egg and the chicken, right? So it's still controversy, yeah, that the root tear first or meniscus extrusion first. Look at the video, show meniscus extrusion first, followed by meniscus tear. This explains why some patient has minor injury, very minor injury, but can cause pain, can cause meniscus tear after the very trivial injury. So that means the extrusion is first, okay, and meniscus torn later. So this paper from Labrat proved that the extrusion may come before the meniscus root tear. So he followed the patient, 27 patients with knee pain without meniscus tear. The serial MRI showed that at 6 months later, it's developed meniscus root tear and progressive extrusion and rapid OA progression. Okay, extrusion first, followed by the root tear. So looking at the degenerative meniscus extrusion, so explained by degenerative process or osteophyte happen on the medial side without root tear. So the osteophyte attenuate the meniscal tibial ligament and cause progressive extrusion. And this is the common situation in the OA patient, early OA patient without root tear or radial tear. So another cause of the extrusion is the extrusion after meniscus transplantation. So from the analysis, they found that sometimes it's because of the oversize, overtension, or the loss of fixation of the root, or non-anatomic insertion, unrestored medial tibial ligament, and absence of native meniscus rim. From the review study found that the incidence of major meniscus extrusion after the transplantation, medial side always more extrude comparing to the lateral side. Okay, you can see 60% and 29%. 29%, that is about half, yeah. So medial side tend to have more extrusion after the transplantation. So this article showed that extrusion group and non-extrusion group has no difference in short term. But in long term, that is the progressive joint space narrowing, okay, after the surgery. So about the osteoarthritis progression depends on the etiology. The trauma patient, traumatic root or radial tear, has progressive osteoarthritis comparing to the degenerative or paraphysiologic. Okay, look at the management. So management depends on the many factors such as etiology, alignment, cartilage lesion, meniscus lesion, extrusion, reducibility. We start conservative first always in degenerative and paraphysiologic. The indication for surgery are failed conservative treatment or traumatic extrusion. Bone collection, always the first, okay? Cartilage procedure if needed, meniscus repair in traumatic case, and transplantation if you have no meniscus. So if you look at this, this is a diagram. It's a bit complicated. Look at the lateral side. The lateral side, when you have extrusion, just 1.1 millimeter is very serious because most of the lateral side has no extrusion. So thinking about the root tear, and you need to address this problem. Okay? Don't wait too long, otherwise it's not easy to reduce the meniscus. So conservative treatment always the first if you have degenerative or paraphysiologic. And these are the surgical procedures, okay, include meniscus repair, radial or root repair, centralization, collective osteotomy, yeah. So meniscus extrusion indication of the reduction is that you have symptomatic pain or mechanical symptom, failed conservative treatment, progressive extrusion. The contradiction is that there's advanced arthritic change like KL 3 or 4, high BMI, malalignment, okay, and no meniscus. So reduction techniques start from simple pulling, MTL release and capsular release, capsular advancement, and the centralization. You can fix by anchor or transtibial, okay? So the meniscus extrusion need to be centralized or not. That depends because the extrusion can persist after the root repair, okay? So from systematic review, the meniscus centralization can improve the knee mechanics. In meta-analysis studies, centralization improve clinical X-ray outcome and also the joint biomechanics. So about the surgical techniques, there's various techniques, but the one that is very popular is from Japan, Dr. Koga. So he used 2 or 3 anchors to centralize the middle meniscus, posteromedial corner, and capsular advancement in horizontal plane centralization technique. So this Koga technique, he do the capsular advancement adjunct with meniscus root tear, okay? So this is his technique. He put the tunnel posterior to the MCL and put the anchor and then wrap around, centralize the meniscus extrusion. But anyway, the outcome is still not reliable. Yeah, we're waiting for the outcome. Mostly, Koga do this with HTO, yeah, in his study. And this is my publication about the meniscus extrusion reduction, okay, same like Koga. Okay, we did that centralization, and you can use anchor, you can use transtibial technique, yeah, put the meniscus in. So the post-op you always protect no weight bearing for 4 to 6 weeks. Okay, this is a case sample. He's a doctor, 52 years old. Patient have so much pain on the middle side. You see the marrow edema and just root tear. I did the root repair for her. She has nice healing, but after that she still have pain. I need to come back again to do HTO. So this patient, I learned that high BMI is not good indication. So once you have high BMI, most time you need to collect the axis, okay? So this is another patient. I did the HTO, root repair, and also extrusion reduction, okay? So this is another surgeon. He is a famous one. Everyone know him well. So he is doing well. I do repair radial tear and also the centralization for him. So this patient have very bad knee, no meniscus. I did the meniscus transplantation with HTO, okay? So he's a good outcome. So in conclusion, conservative first is degenerative or paraphysiologic, okay? But if fail, conservative, do the bone work first, like STO, and cartilage procedure as needed, meniscus repair in all trauma cases, and meniscus transplantation if there's no meniscus. Thank you so much.
Thank you very much.